by the time the slides open, I thank the chairpersons for that nice introduction. It's a pleasure after the long COVID challenge uh, to come physically to Ahmedabad and attend the RSSDI program, which is the 49th annual conference. We have met all our old friends, and I thank the president, Professor Bansi Sabu, my good friend, and the whole team for the nice scientific program. And not only that, we have done many programs virtually in the COVID challenge, but we have come across a opportunity of making it hybrid, 2 days online and 2 days offline, and we all are together here. So you have heard the previous two talks. Urman Dhruv and Jyotirma Paul has very well covered the issue, and I'll just go through little additions what has been already discussed, and you all faced this pandemic situation and the issues related to management of hyperglycemia. Because when we admitted somebody coming with symptoms of chest pain, cough, breathlessness, and then we saw the saturation is falling, and then immediately sent to uh, HDU or ICU, there was a start of steroid, and even the normoglycemic patient, non-diabetic patients, the group of people who had never any metabolic risk, leave aside obese, even normal weight patients had a very high blood glucose there, and it became a big task for all of us, the physician group, to manage COVID as well as to control the type 2 diabetes and the hospital hyperglycemia in the COVID management. So we know that as per the All India Institute and the ICMR guideline, we divided the COVID to be mild, moderate, and severe, depending on the respiratory rate, depending on the saturation. When the respiratory rate went more than 24, it was moderate, more than 30, it was severe, and the saturation was less than 90%, it was severe, less than 93 up to 90 was moderate. And when it was more than 95 with a respiratory rate up to 24 was taken as a patient with mild disease. So all these mild cases were managed at home. They stayed at the home isolation, and the blood glucose management, comorbidity management, COVID management went on at home, monitoring the saturation, fever, breathlessness, and other markers like CRP and D dimer. Worldwide, one thing was common: the COVID-19 shows higher ICU admissions for people with diabetes. So, if you compare patient not hospitalized, patient hospitalized but not in ICU admission and hospitalization status unknown, from all over the world, the patients who were detected hyperglycemia of late were the group who had worse prognosis and increasing chance of mortality and morbidity. And the diabetes increases the mortality in patients with COVID-19 was shown in the Chinese study, Italian study, the New York study, and diabetes was present in the most of the patient whom we lost in this pandemic. Diabetes is a risk factor for greater COVID-19 severity and in hospital death. It is shown all over the world, and the pooled prevalence of established diabetes was almost 14.34%, and the pre-existing diabetes was associated with 2 times higher risk of having severe or critical illness and 3 times increased risk of in-hospital mortality. The association of blood glucose control and the outcome in patients with COVID-19, if we'll see, a retrospective multicentric study clearly shows that the patient with pre-existing diabetes required more intensive in-hospital treatment, and the diabetic status increased the mortality risk of the patients with COVID-19. Significantly higher mortality in patients of diabetes and low risk of all-cause mortality in patients from the well-controlled blood glucose group was the conclusion. So type 2 diabetes is correlated with a higher risk of detrimental comorbidity in patients with COVID-19, and well-controlled blood glucose correlated with improved outcome in infected patients. That was not the Indian experience or experience of any subcontinental finding, but worldwide this was seen. Another interesting finding came the fasting blood glucose as independent risk factor for mortality in COVID-19 patients without previous diagnosis of diabetes. The retrospective multicentric study showed that the hazard ratio was almost 2.3 in the diabetic, and if the fasting blood sugars was more than 7 millimole per liter or more than 200 milligram percent, the mortality increased almost two folds in the patient who were detected hyperglycemic in the ICU. The reasons for the increased risk of infection in people with diabetes was long-term suboptimal glycemic control. We know in India we have around one-fifth of the people with very well controlled blood glucose, and many have poor control, and when they had infection that resulted in catastrophe. The immune response to the viral infection and also to the potential bacterial secondary infection in the lungs was very hazardous. The diabetic complication and the common comorbidity like kidney disease, obesity, ischemic heart disease, which may complicate the situation for people with diabetes, making them frailer in general and increasing the severity of COVID-19 disease. This was the propositions. I'll show this cartoon to show how hyperglycemia worsens the COVID-19 and its prognosis. The cytokine storm and the beta cells both were possibilities from the SARS-CoV-2 infection, and that resulted in insulin resistance and decreased insulin secretion, which ultimately led to hypoglycemia. Hyperglycemia led to the ACE2 glycosylation and the SARS-CoV-2 infection, and the endothelial dysfunction, platelet activation, and AT3 glycosylation resulted in thrombosis and the multi-organ damage. So the COVID-19 in people with diabetes were the reason for the worse outcome. And the hyperglycemia, the older age, the comorbidity, and the obesity contributed to increased risk in these individuals and increased mortality. The poor glycemic control at hospital admission and during the hospital stay worsens outcomes for the patients with COVID-19, and the direct effect of the SARS-CoV-2 on beta cell function and survival, causing worsening, rapid, severe deterioration of the metabolic control in people with pre-existing diabetes or leading to the development of new onset diabetes. The recommendation of glycemic control in India as well as our own organization, the RSSDI, you can see here the American Association for Clinical Endocrinology, the American Diabetic Association, the International Diabetes Federation, and the RSSDI all recommended that the people with diabetes who do not manage their diabetes well and experience the fluctuating blood sugars are generally at risk of a number of diabetes related complications. So this ground made diabetics a priority group for the vaccination when the IDF classified people who belong to at-risk groups are deemed particularly vulnerable, and in priority these people were vaccinated. So this general guide, most people living with the diabetes fell under the IDF group of high risk and were vaccinated. Now I'll see that the discussion that we made, the mild, moderate and severe disease, how it should be dealt with the diabetes control. In mild patients, I'm not going details of the classification, all of you know that. The high risk of the severe disease category were taken people more than 60 years, the cardiovascular disease, the hypertension and the coronary artery disease, the diabetes and other immunocompromised states were taken as high risk and intervened. And the patients were asked to keep anti-diabetic medication, the monitoring facility, and maintain a good glycemic control throughout the disease. guiding those patients. The contact information of the healthcare provider was ready. Adequate stock of medications and the supplies of monitoring blood glucose was ready. Enough stock of simple carbohydrates to combat hypoglycemia was ready. And the glucagon and the ketone strips in case of poor glycemic control was ready. So people with diabetes were prepared to face the pandemic, and good thing happened. The empowerment went to the patient, and many people monitored their blood glucose at home and also reported to their treating physician when it fluctuated. So these particular issues were taken by the patient, and as already discussed, the health awareness increased and the coordination of doctor-patient regarding blood glucose control has increased. What happened in moderate patients who were in the ward or in a hospital setup? They after the clinical improvement were discharged as per the revised discharge criteria, but few people were severe and put to the ICUs. So after clinical improvement, the discharge was done, but these patients, the severe patients, uh, required insulin therapy when it was not well controlled with the oral drugs. So screening of hyperglycemia in every patient hospitalized with COVID-19 at the admission was mandatory. So when the patient reported right from the triage, patient was done with a blood glucose, and one pre-meal and one post-meal value was mandatory with a glucometer. So many patients came with the uh, poorly controlled blood glucose reports, and this was important that to get one pre-meal and one post-meal report. And every patient with diabetes started on a diabetic diet, and they ensured that the patient strictly adhered to the timing and the quantity advised in the diet chart. So the first one was all admitted patients evaluated. If pre-meal was less than 140, post-meal was less than 180, they were advised healthy diet and no need for further monitoring of the blood glucose, the A1C, or the different tests. If pre-meal was more than 140, post-meal more than 180, a complete workup was done. If we got a value of more than 200 milligram per deciliter with osmotic symptoms, we send the fasting and A1C to lab next day. When patients had pre-meal between 140 to 150 and post-meal between 180 to 200, the diabetic diet was advised, and the significant elevation like pre-meal more than 150 and the post-meal more than 200, the diabetic diet advised initiating the oral drugs, and if it is further raised, patient was referred for the insulin therapy. So monitoring the CBG values before breakfast and after lunch and after dinner were done, and the oral drugs like OAD was titrated based on the values. So here I'll take you through three practical scenarios. One is detected to have hyperglycemia at admission on starting steroids. Second is patient on OAD at admission during follow-up. Third is on basal bolus regimen at admission during the follow-up. And fourth is patient nil per oral. So first detected to have hyperglycemia at admission on starting steroids. So we started steroids, likely we'll get a fluctuating blood glucose. If pre-meal was less than 140, post-meal less than 180, the healthy diet and no further monitoring I have already told you. If the pre-meal was more than 140, post-meal more than 180, we monitored the blood glucose level and diabetic diet. It was between 150 to 180 and 200 to 250. We started with metformin twice a day, and if it is more than 180 pre-meal and more than 250 post-meal, we started on basal bolus insulin. Uh, if it is more than 300, right IV insulin infusion was started, and the diabetic ketoacidotic patients were given on on DKA protocol in the ICU. So the oral antidiabetic drug initiated continued in a stable, orally accepting mild COVID-19 cases, and without any contraindication for their use. Gliptin could be vildagliptin, sitagliptin, linagliptin, or teneligliptin, and I'll take you through the oral drug chart again in detail. So in patients on OAD, admission and follow-up, if it is one for less than 140, less than 180, continued OAD, more than 140, more than 180, titrated the OAD, more than 180, more than 250, started on basal bolus, fasting more than 140, add basal insulin at bedtime, pre-meal more than 300, started on IV insulin infusion, and decay started on IV insulin infusion. On basal bolus regimen at admission and follow-up, the pre-meal less than 140, 180, continued basal bolus, more than 140, 180, the optimized the insulin doses, pre-meal more than 300 and post-meal more than 400, IV insulin infusion, decay decay protocol. The patient, if is on nil per oral, the blood glucose level is more than 180. We started with IV insulin infusion. So this is a very important chart, and after that I'll take you quickly through these levels already told by Professor Paul. We didn't allow the patient to go below 110 and more than 180. Acceptable range was 110 to 140 and recommended range was 140 to 180 when patient was in a critical care setup. And all the oral drugs are also discussed. Metformin had no relation to S2 expression in the experimental model or humans. Glitazones increased the S2 expression, and we were little careful, and the sulfonylureas had also no associations. So those who were on drugs with S2 expression increased, they were allowed to continue with the same drug. DPP4, no association. GLP1 and the SGLT2 inhibitors had increased S2 expression, and insulin increased the intrarenal S2 expression by reducing the renal ADM 17. So these drugs were titrated, and the research evidence also promises a hypothetical possibility of insulin being a protective agent. Those patients who are on insulin, by increasing the cell pH, the insulin can potentially lead to the reducing the entry of the COVID-19 virus into the cell, and the current evidence doesn't suggest stopping or changing any diabetic medication in people who were very well controlled with the present regimen. So the low risk of mortality in the patients using metformin, and also the higher risk of those prescribed insulin might be related to the residual confounding like burden of the cardiorenal comorbidity, the historical glycemic burden, and the factors that cannot be fully addressed by the statistical adjustment and the commencement of insulin at the late stage of the disease. So if you ask, is there increased insulin need? Of course, significant hyperglycemia, HSS decay were reported. The COVID-19 induced insulin resistance, dexamethasone induced impaired glucose metabolism, related impaired insulin production was there, which increased the requirement of the insulin. The dose was calculated like this: the prednisolone group, the dexamethasone group, and the hydrocortisone group, the NPH 0.5 and 0.125 and 130, 14% of the basal insulin were taken for the use. And finally, the diabetic ketoacidosis patients were given a ketoacidotic protocol. And the last slide, what I am presenting, tells about the mucormycosis. We know when the sugar went high, when the infection went high, there was chances of a fungal infection, which again created havoc following COVID. So we have to plan the control very well. So to conclude, ladies and gentlemen, COVID changed our approach to diabetes, even empowered our patients, and all the physicians, all the endocrinologists, all the diabetologists have understood the subject very well. Controlling the blood glucose had better chance of recovery and also survival in our patient. Thanks for the time. I thank again for the assignment.
Excellent.